send the message on the group.
Hello, sorry for this connection. I had internet disconnection. So I'm just saying that you have to discard the things and you have also to wash your hands before starting. Why? Because actually I noticed that not only the examiners are the one who assist you, they are assisted even before entering the cubicle. You are assisted way long before entering the cubicle. Especially in the examination station, you are supposed to be washing your hands. That's why the cameras can be following you. And this is part of your assessment sometimes. Before entering the cubicle, I think we could have done this. Seeing the invigilator, by the way, if you notice, the invigilator is making their own notes. Sometimes they make their own notes, especially in the examination station. But if the candidates are washing their hands before entering or not. So you have to make sure about that. Wash your hands in each and every station. It will barely take you 1 or 2 seconds while reading the test. This is number 2. Okay. Number 3, one important thing as well is that you have to verbalize all your findings. I mean, verbalize what you say and what you don't say. For example, when you are looking in the abdominal examination, I could see the abdomen is uniform, not distended. I could see no scars, no mass, no visible pulsation, no abdominal veins, no tuberosity, umbilicus is central and inverted. So you will say no, no, no all the time. Yes, this is not a problem. You have to verbalize everything. You have to show them that you are aware of what you're seeing. And you know everything. Because I noticed that many people do and finish the examination without saying what they found. Some people even used to, like for example, on superficial palpation, the patient gave pain. They still progress to the deep palpation without saying that I could appreciate there is pain in superficial palpation. So you have to verbalize each and everything in the examination. That's why we always study the findings. Like like any OSCE video, they will tell you in the commentary section, no X, no X, no X, no X, no X. Why? Because this is your way of the examination in the OSCE exams or that sort of examinations like the PLAB tool. Excuse me guys, give me a minute. Hello. So the thing here is that you have to verbalize everything, each and everything in that station or in the examination. Do not underestimate that, and do not think that it's time consuming. Okay? Actually, this is the core here. Many examiners think that you are scripted if you do not say or verbalize your findings. Okay, so let's start with the abdominal examination quickly. What I'm going to do, I'm going to tell you the steps in 1 minute for each examination or 2 minutes for each examination. Some examinations may take up to 5 minutes. I just need you to follow with your ears. Okay? Actually, it will be very hard if you do not know the examinations beforehand. At least know the steps. This session is recorded, by the way, and it will be provided to all of you. But I need you, please, do not share the session. Why? Because many academies still teach it this way, and they are missing many things. I don't want anyone to have a look at our efforts or to know about our efforts. So please, this video or this examination session is not for share. Regarding the technique, you will find the technique on YouTube, on any video. I don't mind about the technique. Actually, me myself, I did not follow special technique. In many things or many examination patterns, I used to follow, like maybe some of them from American videos, some of them are from my college, like for example, the way I learned in my college, especially the hernia station. Okay, so it's always advisable to not stick or to not stick to something. However, it's very important to do it on the right way. But please do not share this audio or this record. Okay? Okay. Um, Actually, because also I may need to repeat the course later, so sharing the audios will be a big loss to me. Okay. One last thing, one thing regarding the abdominal examination. I'm going to examine your tummy. So again, I need you to be exposed from below your chest. I can see that you're adequately exposed. Thank you for that. I ensure privacy and will be having a chaperone throughout the procedure. However, if you feel any pain at any point, please let me know. Shall I proceed? Okay. So there are 3 things to cover before each examination, including the abdomen. Number 1, I'm going to tell the patient which examination I'm doing. Abdominal, I'm going to examine your tummy. Number 2, exposure. You need to be exposed from below your chest to your waist. Number 3 as well, comfort. If you feel uncomfortable at any point, please let me know. Number 4, chaperone. Ensure privacy and will be having chaperone throughout the procedure. Number 5, consent. Shall I proceed? Those 4 steps are at least 1 mark of your marking. The examination stations are marked upon many things. One is the examination section. You are marked on many things. These 5 points or these 5 steps are the core of them. Okay, now let's proceed to the examination, to the abdominal examination. What I'm going to do, okay, right now I'm going to ask the patient to maybe lie flat. Okay, so the patient will be lying flat. I will do the tummy examination. Okay, from the side of the patient and from the bedside. From the side of the patient, what I'm going to do, I'm going to have a look at the tummy. I can see that the abdomen, you will verbalize it. For example, you will say, I can see that the abdomen is uniform in shape. Okay, no abdominal distension. No, you will say from the side. So you will say from the side, I can see there is no distension, no mass, no scar. no swelling, no stria, no abnormal dilated veins, no pigmentation, no pulsation. All these things in the abdominal. You can find them in any book. I don't mind. The umbilicus is central and inverted. Mind that in the normal people it is inverted, but in the pregnancy it is everted. But very important thing is that you do not say, remember there is antenatal examination. In the antenatal examination, you do not say that the umbilicus is everted if you do not see it everted on the mannequin. I mean, do not assume things. Just say whatever you see. Okay? Now move to the foot side of the bed or the leg side of the bed. What you are going to do, you are going to say now from the bed side, from the foot side, I can see that the abdomen is uniformly extended. Why? Because I can assess the uniform extension only from the bedside, from the legs, from the foot side of the bed. I mean, to see that if it is regularly, if it is like uniform. If it is uniform, it only assists from the far side. Okay, because in the far side, I can obtain two-dimension view. But from the bedside or from the hand side, I can obtain only one-dimension view. Okay, now move to the palpation. For the palpation, always guys, always please do not forget the temperature. Most of us go to the superficial palpation without doing the temperature. For example, now we are performing the station of the ectopic pregnancy. In the ectopic pregnancy station, I will tell you what to do. You will do definitely abdominal examination as well. Similar steps like we mentioned exactly. But when it comes to the palpation, you are assessing the temperature. 4 quadrants to the thigh, to the mid-thigh. How? You will place the dorsum of your hand on the tummy and then compare it to the mid-thigh. Same to other quadrants as well. 4 quadrants. Lower quadrant, lower right, lower left. Upper right, upper left. Just 4 are very enough. And compare each of them to the mid-thigh. You will palpate the quadrant, then the thigh. Quadrant, then the thigh. What's next? You are going to say that I can appreciate your local rise in temperature. Now I'm going to touch your tummy. If you have any pain, do let me know. For superficial palpation. What you're going to do in the abdominal, you're going to do, S-shaped palpation from the medical school, if you remember. S-shaped palpation. Please, when you are doing this, you have to look at the face of the patient. Please look at the face of the patient. How? Many stations there's only mannequin. I mean, there is no real patient to perform examination on. But you'll find that the patient is sitting just beside the mannequin, which means that you can be performing the examination while looking at the patient face. So just do the superficial palpation and look at the patient face, the real patient face. What you're going to find, for example, you're going to find in the ectopic pregnancy, you are going to find left iliac fossa or right iliac fossa tenderness. He will show you some, ouch. So what you're going to do, I'm so sorry, can I proceed further? He will tell you, no, doctor, no, please, it's painful. She will tell you, no, doctor, it's painful. Okay, what if she doesn't tell you, no, doctor, it's painful? When you proceed, when you proceed after this point, she will try to show you that she is not comfortable with that. And you even will not be having too much time to perform. Why? Because usually the abdominal examination stations are long. So the moment you reach superficial palpation, you are almost done with the examination. If you are still left with any further time, you can do the deep palpation as well. Okay, so I could find tenderness. I would see that I could find tenderness on the left iliac fossa. Now, usually the 2-minute spell will ring. So what you're going to do, you're going to disclose from my assessment team that you're having a condition we call ectopic pregnancy. What is this? Doctor, it is a condition which you can explain then later. So it is very similar to the history-based station apart from the fact that you have to perform the examinations after the history. This is one thing. Abdominal examination can be found in the ectopic pregnancy station. It can be found as well in the abdominal aortic aneurysm station. This is number 2. Number three, it can be also present in the diverticulitis station. What is diverticulitis? By the way, can anyone tell me what's diverticulitis? Explain it to me in the normal patient language. Dr. Muniba, good morning.
Good morning. Okay, so I would explain to the patient that our large bowel had uh, sometimes inside the large bowel there is outpouching, and the bacteria gets stuck in it and can cause inflammation.
Exactly. So simply it is outpouching in the wall or the bowl of our bowl, which usually happens for no reason most of the times. But when this happens, the feces get trapped in it and it attracts bacteria, which cause infection. How to treat the diverticulitis? Diverticulitis simply admission to the hospital. Number one, it is like any surgical problem. How? You will do 3 in and 3 out. Most importantly, painkiller and IV fluids and antibiotics, and then 3 out, monitor the urine output and monitor or take some samples and maybe nasogastric tube as well. Okay, very important that most of the cases, this can be done under surgery. Okay, so diverticulitis simply will be done under surgery. Okay, guys, so other station for the abdominal examination is that there is chronic diarrhea. I got this station by the way before. This station is not clear so far yet for many people, but let me demonstrate one or two things for you. The girl is very nice, she is helpful. You will elaborate the diarrhea, you will find no exclusive or nothing conclusive in the elaboration of the diarrhea. No positive findings, only diarrhea since 4 months, which is the same. It hasn't changed and nothing has been done. No blood in it, no abdominal content or no abdominal color in it, no constipation, no fever, no tummy pain, nothing else. What are your differentials here? Your differentials could be inflammatory bowel disease, could be cancer as well, could be celiac disease, and could be hyperthyroidism. I ruled out the most important two things, which are the cancer and the IBD. When you do the examination, you will find what? You will find tenderness on the. Actually, what happened to me is that I told her I need to examine you, and I was forgetting that it's combined station. Actually, not all of us knew it. So when I said I'm going to examine you, she pooped on the couch. I was very shocked because I was barely having 3 minutes in station remaining. So please, if you find a couch in the cubicle, be prepared to any examination at any time. If you find a couch in the cubicle, be prepared to an examination anytime. Why? Because you do change scenarios sometimes. Sometimes you know that it's history-based station, but when you enter, you can find it examination station. So she popped on the couch and I did the abdominal examination, but on superficial palpation I found tenderness. I asked her, shall I proceed? She said, no, no, doctor, please don't do it. It's painful. Okay, thank you. Cover yourself again. Do you know what's going on? Actually, for my assessment team, please, you will say this. It seems that you're having a problem with your bone or a problem in your gut. Doctor, what is this? At this point, it's difficult to say. That's why we need to run further investigations. Which investigations, doctor? See, now you're going to perform all the investigations. Remember, in any case of prolonged diarrhea, number one, routine bloods. Number two, blood antibodies and culture. Number three, urine, dipstick and urine culture. Number four, stool analysis. Number five, some scans. Some scans are very important here. Why? Because she'll ask you scans. Do you have any concern? Yes, doctor. I heard also about a camera scan or a camera test. So now she's basically interested in the colonoscopy, or she knows that you're going to perform colonoscopy or not. So the colonoscopy is also one of the investigations to be done here. Now she will ask you one or two questions regarding the colonoscopy, and is it really important? Doctor, is it cancer? Again, the same thing. She doesn't have symptoms suggestive of cancer. However, to perform or to confirm or to find out the cause, we need to do further investigations. One question she may ask you, she may insist on knowing a diagnosis. Like for example, but what it could be, doctor, what it could be. If she insists on you, what happened? She insisted on me actually, doctor, but what it could be this problem? What it could be this problem? You can tell her we need to do these investigations. However, if all these investigations come back normal, I can say that you're having a condition called irritable bowel syndrome. Irritable bowel syndrome. Okay, that's it. So simply, when someone insists on knowing a diagnosis for long-standing case, which you don't even know, simply say the simple thing that you can suspect when you are FY2, when you are just a junior graduate. Why does she do this? Because most of the people can say it could be cancer. Most of the people say that it could be inflammatory, but actually they are right. It could be cancer, it could be inflammatory bowel disease. But can you do this without further test? No. So please don't even bring the possibility unless she asks about it. So here you can say that I'm suspecting you're having irritable bowel syndrome. Okay, one other station for the abdominal examination station. I told you before, in the abdominal examination, in the aortic aneurysm, it can be, most probably, it can be combined station in which you should perform the abdominal examination. Okay, it is the same pattern as any abdominal examination, but please make sure that you do the aneurysm special test. What is the special test of the aneurysm here? Simply, you place both hands on both sides of the umbilicus. Press with one hand and feel with the other hand. Exactly like thyroid. Press with one hand and feel with the other hand. Why? Because this way you are pressing on a pulsatile mass. The pulsation will be more prominent on the other hand if you do this. This is the abdominal aneurysm station. So you are going to do number 1, inspection, number 2, palpation, including temperature, then superficial palpation, then deep palpation. In the deep palpation, you are going to perform full deep palpation, and after it, you're going to, when you are deeply palpating, you will feel a pulsatile mass. When you feel this pulsatile mass, please do the aneurysm special test. And you will say that I could appreciate the pulsatile mass on deep palpation or aneurysm test. Sometimes in the inspection, you can see visible pulsation. So please say I could see visible pulsations here. But if you do not say them, if you do not see them, do not say them. Do not assume things at all. Okay? So those are the abdominal. By the way, sometimes it came recently that in UTI station, in which you have to put catheter, sometimes instead of putting catheter, instead of putting such things, they bring it as UTI. It is just UTI in a female, and you have to do abdominal examination. So the UTI station, sometime right now, sometimes come as a combined station. Okay, and with a mannequin. So what you expect in the findings here? She's having UTI. Can anyone guess about it? Dr. Zaid, can you help me with that? Hello?
Hello, Doctor. Hello, hi. We can find in the examination there is temperature probably difference between the abdomen and the thigh, and there is tenderness in the lower tummy.
Exactly. So basically, yes, you are going to find suprapubic tenderness, most probably. You can find suprapubic tenderness or pain. Thank you, Dr. Zaid.
Thank you.
Okay, so this is the cystitis, but definitely in the urinary catheter, you'll be having like bladder distension, bladder fullness. So in the other station of the urinary catheter, the bladder is full. The patient cannot pass urine. So you will find suprapubic tenderness and fullness. Not only this, if you do percussion, you will find dullness sometimes. Okay, okay. So it can come as a mannequin. I mean, this abdominal examination of the UTI, and very similar in the end of the station, you will write antibiotics or you will give antibiotics as well. This is regarding the abdominal. Let's move to another interesting station which we have discussed already long ago, which is the chest examination. Remember, this was in our second session in the course. In the medicine stations, we discussed it with the ACS and the angina and the herpes zoster and the pulmonary embolism and other causes of chest problem. Simply in the chest examination station, I told you before about it and we explained in details. The patient is lying on a couch and he's complaining of chest pain, and he had a trauma or he had a fall from the bicycle 2 days ago. So we are going to perform chest examination in this station, like inspection, palpation, including temperature and superficial palpation. For superficial palpation, why I'm doing it? Because I'm suspecting tenderness on one side of the chest. Why? Tenderness usually comes with costochondritis. He's having costochondritis, so you have to check the tenderness. How to do that? Simply roll your fingers and thumb just far away from the pain site till the pain site. Like any superficial palpation, I run my finger or I palpate from further to closer till when I get to the point the patient will give me pain. Then after superficial, you will do the chest compression. What is the chest expansion? Sorry, chest expansion is the depulpation of the chest. There is nothing called depulpation. Depulpation of chest is done as chest expansion. After that, you are going to do percussion, okay, and then auscultation. The chest examination here in this case should not take you more than 2 minutes. Okay, it's very easy by the way. So after that, you are going to do the investigation. What are your differentials here, by the way, Dr. Bina? In this chest station, what are your differentials?
It could be angina.
Okay, thank you. What
and musculoskeletal trauma, any trauma. It could be pneumonia, any chest infection.
Exactly. Exactly. Thank you. So here in this case, we are going to do some investigations. You know, Dr. Bina, which investigations here to be done?
Yes, we'll start with blood tests.
Yeah.
Including troponins.
Very good. What else?
Chest X-ray.
Okay, very good.
And ECG.
Thank you so much. Thank you.
Thank you.
So why no, say wait. Why are we doing this investigation? If the examiner asks Dr. Bina, if the examiner asks you why you are doing all these investigations,
to rule out other causes that could have caused the chest pain.
like what?
Like MI and infections.
Thank you. Thank you. And pneumothorax. Okay. Okay. So now we are going to disclose the patient. You are having problem in your chest, most probably chest injury or chest trauma. Okay, and we will discuss it in the same way that we said in the course. You mean when we were discussing this station, it was explained in details, the management. This is the chest station. Okay, let's move to some more difficult stations. We're going right now to start with the blood sampling. The blood sampling station, actually, the patient has taken many paracetamol tablets, okay, and this was 4 to 6 hours ago. Okay, they have taken at least maybe 22 or 23 tablets since I told you 4 to 6 hours ago. And they are here to you in the A&E. By the way, the task here tells you take blood sampling, talk to the patient, and address her concern. So here your priority in the task should be taking blood sample. I mean, before taking history, you should take the blood sample. What you're going to do here, enter, greet the patient. How are you? Actually, I'm just worried. I took some pills. May you know which pills? Paracetamol nature. And after that, he will ask, when did you take it? You will say, doctor, I took it maybe 2 or 3 hours, 4 or 6 hours ago. So thank you. Can you bear with me for a few minutes? I'm going to do some procedure we call blood sampling, in which I take a sample from the vein in your arm to test the level of the blood for the paracetamol and some other things as well. For the purpose of this examination, I need your arm to be exposed. I can see that it's adequately exposed. Thank you for that. I will ensure your privacy and we'll be having a chaperone. If you feel any pain at any point, please do let me know. Do you have any vein preference, any arm preference, any vein or arm soreness? Shall I proceed? These steps are found in the videos, okay? But I need you to mind 2 or 3 things. Number one, most of the people usually, what are the steps? What are the steps again? Number one, you are going to gather your stuff, gather your equipment. Number two, please place the tourniquet under the arm in a loose way. And then you are going to do alcohol swab. Then, before alcohol swab, you are going to tighten the tourniquet. Then do alcohol swab, one way only. Again, one way only, which means that you should not do it back and forth, only one swab. And then throw it in the clinical waste bin. Now take a sample and attach the vacuum thinner and withdraw blood. Whenever there is a blood gush, please remove the tourniquet. And after that, simply you're going to check the vacuum thinner and send it for further investigations like what? Routine blood including full blood count, liver and kidney and thyroid function test, and the paracetamol concentration. One thing is that if you finish the station without throwing the needles in the sharp spoon, you will feel it. If you finish the station without throwing them in the sharp needle, you are going to feel it. Okay, one important point as well is that you are assuming you are gloved in any examination station. And this usually comes after gathering your equipment in the beginning. So while you gather your equipment and you open the things, for example, you open the cannula, you open the catheter, you open whatever, in non-touch technique, which means that you should not touch them. After opening the outer packaging of most of the instruments, now you can put the gloves. Why? Because wisely, you cannot put the gloves unless you open the things which can be potentially unsterile. So usually you assume you're gloved right after gathering and opening the equipment. In the paracetamol level overdose, you will continue taking history, or for example, how much, how do you take them in one go or with other things? Have you taken anything alongside them like alcohol, any drugs? And now for the elaboration. Management is still similar. We need to keep you in the hospital, but in this station, the examiner may provide you with a curve or with a graph. Very simple. He will provide you with a graph which contains the timing and normal level. You will find that the level of the paracetamol in his blood is high from the graph or from the curve. So if the level is high, it means that you need to start to admit and to start treatment. This is another thing. Other station is the cannulation. And the cannulation station is similar to the blood sampling in many things, but here actually this is post-operative pain. So post-operative pain is usually having many possibilities. Some of them are like complication of surgery. Some other are infection inside of surgery. Some others are maybe internal obstruction because this was an appendectomy surgery. Sorry. So what you're going to do here, you're going to start the station by elaborating the pain which the patient will give you. They will give you some pain in the tummy. But the test tells you that the cannula has been blocked and the patient is supposed to receive a painkiller. Do the cannulation or change the cannula, talk to the patient and address his concern. Also, you talk to the patient, change the cannula, and address his concern. So here you're going to elaborate the tummy pain which come after surgery. You're going also to ask about fever, any bloating, or any nausea, vomiting. Now, tell the patient that you know the cannula has been blocked and they should receive another painkiller. For that, I'm going to change your cannula to give you painkiller right away. Before giving you painkiller, which contraindications we need to rule? Like number one, do you have any medical condition? Do you take any medications? Do you have any allergy to any food or drugs? Shall I proceed? Now change the cannulation or now start your procedure by changing the cannula. I will send you two videos for the cannula. One from Aspire videos and the other one is from another academy or another school. Both are right. Do not stick to one of them. I mean, try to pick up what comforts you. Okay? So the most important thing is that you are going to throw your things after finishing the procedure as well. Okay? Okay. Now move to the, you have done the cannulation, right? Do the examination. I mean verbalize the examination because the examiner may give you a news chart in this section, upon which the management will depend. What will be the news chart? They can give you low oxygen, they can give you, for example, high temperature, they can give you vomiting, they can give you anything. So what will be your management? Number one, documentation of the procedure. Any procedure I do, I document it. Number two, I'm going to inform my senior as well, and we are going to assess the patient vitals. What are the vitals? According to the news chart, if the oxygen is low, we're going to give oxygen. Blood pressure is low, we're going to give IV fluids. ABC. Then, what we are going to do? We're going to give her something for the vomiting or for the sickness, like metoclopramide. Okay. After that, we are going to do something or to give her something for the pain. The examiner may tell you, doctor, she has taken paracetamol before. Or maybe he will tell you, doctor, she hasn't taken anything. So in this case, actually, you're going to give her morphine after discussing with your senior. How much morphine? How much? Most probably you give 5 milligrams, but you can give 2 to 10 titrations. 2 to 10 titrations, which means that according to the severity of the pain, from 2 to 10. What is the antidote of the morphine? Naloxone. In any patient whom you are giving morphine, you have to make sure that he has been prescribed naloxone alongside it, just in case there is respiratory problem due to morphine. Okay, so please mind the news chart in this case. This is the cannulation. Then let's move to the interesting part, the devices, which are the otoscopy and the fundoscopy as well. In the otoscopy, it is an otitis media station. Otitis media, simply the presentation is ear pain. You will elaborate it and ask about the redness or swelling or discharge. DDs here are meningitis, could be respiratory tract infection as well. And usually the recent health contains history of upper respiratory tract infection. Do the examination. I'm going to examine your ear using certain device. I need your ear to be adequately exposed. Thank you for that. I ensure privacy and will be having chaperones throughout the procedure. Okay, may I proceed? Now what you're going to do? We are going to start with the inspection. On inspection of the ear, I can see on inspection of the ear, I can see that there is no pain here. Sorry, in the inspection of the ear, I can see there is no mass here, no discharge, no swelling, and no wax coming from the ear. So on the ear inspection, I have to comment on that. And it's better if you comment like pre-auricular, auricular, and post-auricular. Like pre-auricular, I can't see no mass, no swelling, no scar. On the auricular, I can see there is no mass, no discharge. On the post-auricular, I can see there is no mass, no swelling, no scar. Again. And you will do it on both ears. You will do that on both ears, please. Not only the affected one. Now move to the palpation. Which palpation? Again, pre-auricular, auricular, and post-auricular. Plus tragus test. Do not forget the tragus test in any ear station. Do not forget why. It's important to rule out one differential for you. Otitis externa. So please do not forget it. After that, okay, you will do that on both ears as well. After that, you can introduce the otoscopy into the affected ear, not the normal ear first. You will say ideally you start with the normal ear. Then you introduce the otoscope in the affected ear. Why we do this? To save time. Because in this station you will barely have the time to, you will do that at 6 minutes long, the otoscope thing. So it's much better if you are fast and you are starting from the affected ear. Usually you hold it as a pin. The otoscope, you will hold it as a pin. And for the right ear, you will hold it with your right hand. And for your left ear, you will hold it with your left hand. Okay? Give me 1 minute, guys. Hello? So simply here, you're going to hold it with the right hand if you are performing the right ear. And if you are doing the left ear, you will do the left hand. Okay? One important thing which fails many people is that you have to change the earpiece before starting the otoscope. You will have an earpiece, okay, or you may not be having it as well, but it's very important to ask the examiner, I need earpiece. I need to change it to prove that you're a safe doctor. Okay, so you will change the earpiece. If you do not do this, you may fail the session. So change the earpiece before going to the mannequin. Okay, by the way, you will perform the whole examination of the mannequin. The examiner will not let you do it in the patient. So please change the earpiece and comment on it. What's your comment here? You will place it inside and then you will say, I can see the tympanic membrane is red and congested and inflamed or edematous. This is pink shade in color. Number two. Number two, no visible cone, no visible light reflex. I mean, the cone of light, nor the light reflex, nor the umbo are visible. Pars tensa and pars flaccida are not visible as well. The comment is similar to the videos as well. It's very straightforward. It doesn't change. So no visible pars tensa, no flaccida, no visible cone of light, no light reflex. The tympanic membrane is red and congested and inflamed. Tympanic membrane is pinkish red in color. My most probable diagnosis is acute otitis media. Ideally, I would do the other ear. Sorry to say. How can we allocate the waist area in the cannula? What do you mean by allocate the waist area in the cannula, Dr. Zaid?
Dr. Ahmed, how are you? Hi. Just the problem that in my station, in my exams, when I said to the examiner, where is my clean area? He showed to me, and when he showed to, I told him, where is my waist area? He showed to me to a dustbin.
To what? Excuse me?
To the pin. Yeah.
Mm-hmm.
So it was away from the mannequin.
Well,
So this was, yeah.
Simply, you can, in the beginning, before putting your gloves and before putting anything, you can bring the sharp spin closer, because you are not supposed to hold it with your hands up all the way to the sharp spin.
No, the sharp pins was closer to me, but
Okay.
the waist area, it wasn't closer to the mannequin. I meant the dustbin. He just pointed to the dustbin. You know the pin, the waist pin.
Yeah, sure. Yeah. By the way, there was no extra trail.
I'm sorry.
There was no extra trail.
No, I couldn't find.
Okay. In this case, simply, how far was it from you? How far was it?
It was about 1 meter.
1 meter.
Yeah.
Which means that you have to take few steps to reach it.
Yeah.
Hmm.
Yeah, to be frank with you, yes, it was 1 meter about.
And it was in the cannula station.
No, it wasn't. It wasn't in the. It was in catheter station. Yeah.
In the catheter.
Yeah.
No, in this case, you have to pull it closer.
Oh, the dustbin, right?
Yeah. You have to pull it closer. Why?
Yeah.
Because if there was extra trail, you can put your stuff in the trail at least till you finish. And then after that, you will place the whole content of the trail in the bin, in the clinical waste bin or the dust bin.
Yeah.
But here, in this case, as it's far and there is no extra trail, you have to bring it closer to you because you need to throw the stuff instantly in the clinical waste bin.
Yeah. Okay, thank you.
You're welcome. So, okay. So one important thing here is that in the otoscopy, you have to change the earpiece, and the management will be otitis media. Now let's move to the fundoscopy. In the fundoscopy, it's very simple, but I just need you before proceeding, it's a GCA station. GCA, which is like, there is no retinal change usually in the GCA. GCA simply, the loss of vision is due to problem in the artery, the temporal artery. So it has nothing to be done with the retina. So in this case, you will find the eye examination unnormal. What are your differentials here? I will rule out maybe meningitis and central retinal artery occlusion. For that, and the retinal detachment as well. For that, I'm going to ask, have you seen any floaters or flashes? And have you noticed any curtain coming down before your eyes? For the eye examination, I'm going to start with the inspection. Okay, why? Because before proceeding to the eye examination, I need to rule out glaucoma. Shining a bright light into the eye and dimming the light before that may worsen any glaucoma. I mean, dimming the light can worsen any glaucoma. So I need to rule out glaucoma before proceeding to the fundoscopy. So simply, I'm going to ask the patient two questions. Do you have any pain? Have you seen any halos around the light? Do you see or do you have any pain in the back of the eye? because these are two questions specific for the glaucoma. If they are negative, now examine the eye. Start with the inspection and then no palpation here. What you are going to do here, direct fundoscopy and red reflex. Now start with the red reflex because we start from outside till inside. We're going to ask to dim the light. You should dim the light actually. Sometimes the examiner may let you do it with the patient. Some other times the examiner will let you do it on the mannequin. Most of the times on the mannequin. So you will dim the light. Why? Because the red reflex cannot be demonstrated unless the light is dimmed. So if you do not dim the light, you are not passing this examination. So dim the light, perform it on the both sides, the red reflex. One hint is that you have to stand at an angle from the eye for the red reflex. Like for example, 45 degrees from the eye and few steps away. Again, 45 degrees and few steps away. You don't stay or stand right before the eye, okay? And you do not stand closer to the eye. So 45 degrees and few steps away on both sides. And you will see that the red reflex is present. Before proceeding to the red reflex, you have to set the fundoscope. Learn how to set the fundoscope from your academy or from when you hold it, because please, it can change sometimes. You can enter the cubicle, you can find that the previous candidate has adjusted it according to his vision. You know, in any eye device, always there is an option to set the device on your vision, based on your vision or on your eyesight. So please make sure that it is suitable for your eyesight. Why? Because if you do it like blindly, you will look very scripted and you will look very bad. So please try to show some manipulation, some like commandment of it. And after that, you are going to perform the fundoscopy. How to perform fundoscopy? You are coming very closer to the eye, very close. Now you have to dim the light of the fundoscope. Why? Okay, so now let's assume it, or let's summarize it. You dim the light of the room before going to the red reflex, but you kept the light of the fundoscope. But now we are even dimming the light of the fundoscope to see the fundus. Why? Because there is light coming from the back of the retina. If there is a light coming in the mannequin from behind and you are shining light from the front, this can confuse both of them. So it's better to dim the light here in the fundoscope when you are doing fundus examination. Yes, you are applying mydriatic eye drops as well. Why to dilate the eye? So this is a good point. Thank you for reminding me, Dr. Muniba. You are going after the eye examination or after ruling out glaucoma, you are going to apply mydriatic eye drops. And after the mydriatic eye drops, what you are going to do, you are going to do the red reflex, and after the red reflex as well, you are going to do the fundus examination. So again, you are dimming the light in the fundus. For example, you tell the patient, ideally, I would turn my light on. But definitely here you have to dim the light because the mannequin is having light from the behind. What's your comment here? I can see the optic disc. Optic disc is pinkish yellowish in color. Optic disc to cup ratio is normal. Macula seems to be healthy. No dilated blood vessels nor tortuous blood vessels. My most probable diagnosis is normal fundus. Again, optic disc, I can see the optic disc which is pinkish yellowish in color. Optic disc to cup ratio is normal. No abnormal dilated nor tortuous blood vessels. Macula seems to be healthy. My most probable diagnosis is normal fundus. Okay, you can do this on both eyes as well. So here you can do on both eyes in this station. Your diagnosis here will be GCA. And now you explain the GCA and everything. Okay, let's move to the next one, which is the urinary catheter. Urinary catheter is a little bit
Dr. Ahmed, I'm sorry.
Yes.
So just regarding the fundoscopy, in most of the cases, this is normal, right?
Yeah, not most, all of the cases. I mean in PLAB 2 so far.
Yeah, no need to see no know about the diabetic retinopathy, hypertension?
Well,
No.
it's better. It's better if you know about them. But of course, it will. You know why? Because there is a station. You know the combined station, the counseling station, which is patients having diabetic retinopathy.
Yeah.
They can change it at any point. Like for example, instead of telling you that the GP letter showed retinal changes, they can now bring it to you as a patient who's coming for diabetic review, and he's here for the follow-up of diabetes, and he's having very vision. So when you do the fundoscopy, you can find diabetic changes.
Mm-hmm.
So that's why I do, but it's very easy to predict. I just
Honestly,
recommend, yeah.
yeah, because of the in Swami mannequins, there is one mannequins which with different views, different pictures, so they can adjust the pictures.
Yeah, and
So,
in our academy as well, and in Samsung and all the academies, you know, they can change the picture at any time. But the thing is that mostly it came right now, or it comes as GCM only. But
so
what is the problem if you know about the diabetic and maybe the retinal the changes, like for example the central retinal artery occlusion? Very enough to know two more, and they are very easy anyway. You will know them.
yeah, but the mostly is to say to say to the examiner the steps. I can see the macula, I can see the
Yeah,
fundoscopy.
yeah,
Yeah, these are the important things. So we
yeah,
will not concentrate on the. I
yeah.
think it's not to see the white cotton or those things.
No,
Yeah,
actually, what happens? What happens is that you. That's why I'm always telling you, please verbalize what you see.
yeah.
If you verbalize what you see, you will not get lost, even if even if the station changes.
Mm-hmm.
You're telling the examiner that I could see this and this and this, but
Mm-hmm.
still I cannot point the diagnosis because I'm not sure about it. That's fine,
Mm-hmm.
but just
Okay,
at least verbalize it.
fine.
Okay, so it's normally only. Yeah, it's not. Yes, I'm sorry, I just saw your question. Um, okay, let's move to that urinary catheter here. In the urinary catheter station, the patient usually is having very bad tummy pain and burning sensation in the urine or inability to pass urine, sorry. So tummy pain and inability to pass urine. This is urine retention, acute urinary retention. Okay, what you're going to do, elaborate both things, and now tell the patient I'm going to do a procedure to relieve your pain. But before that, I need to examine your vitals and your general physical and your tummy. Why vitals? Because I need to know the blood pressure of this patient. Why general physical? Because I need to see if there is any blood in the tip of the urethral meatus. Why? This is a contraindication to the urinary catheter. And let's do also the abdominal examination, the tummy examination. We said a few minutes back that you will find suprapubic fullness and tenderness in the tummy examination in this case. Why? Due to distended bladder. So you are going to insert some flexible tube. You are telling the patient I'm going to insert some flexible tube. Which one? The catheter? It's just a little bit long, but it's easy. I will tell you something. You will put the catheter simply. How to put the catheter? First of all, gather your equipment. One important tip here to do is that you are gathering the equipment, and after that you are opening the things in non-touch technique. After opening them in non-touch technique, you will assume that you are double gloved. So after opening in non-touch technique, you assume that you are double gloved. Please mind that. Then what to do? Apply the drape. The drape, which is a little bit sort of cover with a window to expose only the penis. And after that, you are going to place the trail under the penis. What's next? You open the things. Now you can insert, before inserting the catheter, you can right now first of all, you can put a dressing on the shaft of the penis. You will see the steps everywhere. And then a dressing on the top or the tip of the penis. Okay. One important thing is that do not forget that they provide you with a gel. So do not pretend that you are cleaning without the gel. So there is a gel, there's a pot containing gel beside you. So you have to soak the dressing in the gel. You have to soak it. clean the penis. Okay, now apply the numbing gel or apply the local anesthetic gel. Tell the patient that cold sensation is coming, and it will usually take few minutes to work. Now, introduce the catheter. In the catheter, you have to do one or two things. Number one, you are lifting the penis a little bit with your non-dominant hand, which is your left hand, and you are inserting the catheter with the other hand. Please do not pull the catheter many times, because if you pull it while inserting, this means that the catheter will be dislocated. You drop the catheter, I will tell you, because actually the problem in this station is that the space is limited. The space is limited. You are dealing with many things in a narrow space. You have to push the catheter all the way inside, and the most important thing is that you should not waste or ruin your sterilization. How? Push the catheter inside without touching the penis. Do not touch the penis at all, because the penis now is sterilized after applying the gel over it. After finishing the steps, you will secure the bag. You will attach the bag to the tip of the catheter. Okay. Sorry, you will flush first on one side of the catheter, and after that you will insert the bag. After inserting the bag, you have to look at the urine color and volume. The examiner will not reply to you. Then attach the bag to the side, to the thigh of the patient, or to the side of the legs of the patient. Sorry, attach the catheter to the side of the legs of the patient and attach the bag to the side of the bed. The bag will be attached to the side of the bed, while the catheter will be attached to the side of the legs. You will just assume this. You will not do it real. You will just say that ideally I will attach it or I will stick it to the side of the patient and to the side of the legs of the patient, the bag. What's next? How are you feeling right now? Oh, doctor, I'm feeling better, thank you. Okay, do you have anything else? Now we will give you prostate symptoms. So definitely he was having urinary retention on top of BPH. Which examinations to do after BPH? Simply tummy examination and rectal examination as well. Yeah, it enters completely, except for the last branch, like the branching. With the branching, in which there is two outlets, the flush and the bag hole. Okay, so we insert the catheter fully till the Y junction, this branching. Okay. So one very important thing here in the catheter station is that you check the patient comfort and you throw all the things in the clinical waste bin. If you don't throw them, you're not likely to pass it. Again, you have to throw everything in the clinical waste bin. Otherwise, you are not going to pass it. See, this is unfair? Yes, what happens? Okay, so now we will give you prostate symptoms, which examination, tummy and PR. After the tummy and the PR examination, which you will get bilateral enlarged smooth prostate. Okay, in this case, simply you now start the management. You are having a condition we call acute retention due to prostate problems. What's prostate problems, doctor? Now you tell him benign prostatic enlargement. We'll explain it like the same way we used to do before. For that, we need to keep you in the hospital. Why, doctor? Now you will say, we will keep this patient in the hospital. Why? To monitor his urine output in terms of color and volume. To monitor as well his blood pressure, lying and standing blood pressure. We can give him some medications, like what? Like Tamsul, like finasteride. Medication to shrink the prostate and medication to relax the bladder. And you are going to follow his urine, as I told you, or monitor his urine. And you will keep him in the room for a while. If everything goes smoothly, he can be sent home like tonight or in the next day. However, we will need to teach him how to change the bag at home. He will come back to us in 2 weeks from now to do something called trial without urinary catheter. What is this trial? Simply, it is a trial in which to see the patient's ability to void without the catheter, if he can void without the catheter or not. And it will be guided by ultrasonography. Okay, this is the urinary catheter station. Like as Dr. Zaid and Dr. Elvira said, it is one of the challenging stations. Yeah, one of the challenging stations, but it's so. You know, the problem is that most of the people are confused in the catheter itself. So what I suggest is that you buy your own catheter before going to UK. Yeah, you have to do this. Buy it either from your country or buy it even ask someone who works in a hospital in UK to bring it to you. Okay, please do that. Yeah, that's why I told you. Bring it from the hospital, not from the academy. Bring it from your country as well, just to learn how to fix it if possible. And after that, you have to perform it all of it in 3 minutes. Please train yourself to perform it in 3 minutes or even less, ultimately in 2.5 or 3 minutes. This way you will be left with 2 minutes for history and 1 minute for the prostate symptoms. Or at least 1.5 minutes for the prostate symptoms. And then in the management, it's very easy. You just keep in the hospital and do some other few things. Okay, let's move to the other stations, which are the breast stations. In the breast station, simply, there can be 2 sets of the breast. They can be either breast lump and normal breast. In the breast, simply, what you're going to do, number 1, explain the procedure as we agreed the 5 steps. Then, for the breast examination itself, we are asking the patient to examine in 2 different positions. Number 1, sitting upright. Number 1, sitting upright with placing the hand on the thigh. Number 2, bending a little bit forward with placing the hands in the waist. And number 3, sitting upright with placing the hands or the arms below the head. And in each section you have to comment. Okay? Okay. As well, everything is present in the videos. But I just need you to do or to know one thing. You have to verbalize all your findings here. Do not ignore or do not overlook the verbalization in this stage. Exactly. Do not do this. Okay? So this is the thing here. After that, you're going to do palpation. While palpation, look at the patient's face, definitely after temperature. In the temperature, you are comparing each quadrant to the opposite quadrant. Upper outer to upper outer, lower outer to lower outer. So you compare each quadrant of the breast with one another on the opposite side. Superficial palpation, you will do it anti-clockwise, but look at the patient's face. You will do, by the way, you will do the examination on both sides. Finish inspection here, do inspection here. Finish inspection, finish palpation here, do palpation, and this. The only problem is that in deep palpation you will find a mass, most probably in the right upper quadrant. What are you going to confirm? Number 1 is the site. Number 1 is the size. Number 3 is the shape. Number 4, the attachment to the overlying skin or overlying structure. Number 5, if there is any skin change, if there is any pain on the mass or not. And you will attach or you will comment also on the consistency in the surface. For example, usually it is regular, and firm, regular and firm. Okay, now we found the breast lump. You are not supposed to give a diagnosis. You will just say, as a similar breast stations, we need to do further tests. Which test we are going to refer you to specialists here. Again, you will give an appointment in the hospital. The hospital will contact her and they will give her an appointment in the breast clinic or with a breast specialist. What they will do, history examination, especially including mammogram, and they may take some sample from it. The same thing from the breast stations. So here you can find the breast lump unilaterally. Okay, you are supposed to do on the other side as well after finishing this side. And one important thing, when you find the lump, do not stop your examination here. Continue examining even the same breast. Maybe you can find another lump in the same breast. And after finishing this breast, you can go to the other side as well, if you have time. If you do not have time, please move to the management. The other station is cyclical depalpation. Depalpation simply, you are going to tell the patient, I'm going to press deeper over your breast. You will start from low determinable, low, anti-clockwise. 6 o'clock, 6 o'clock, anti-clockwise. Okay, 6 o'clock anti-clockwise, and then press deep, press deep. Do not touch the areola, do not touch the areola. Here, you're just doing it from far from the areola. Okay, and then you found a mass, for example, in the right upper quadrant. We're going to comment on that. Number 1, size of the mass. Number 2, size of the mass. Number 3, consistency of the mass, usually firm. Number 4, surface of the mass, usually irregular surface, regular. Number 5, painful or not. Number 6, attachment to the underlying structures or the overlying skin. After that as well, I told you about the deep palpation. If you have time, you can perform the peri-areolar palpation. How the peri-areolar? You place your thumb around the areola and keep rolling it. This is the deep palpation of the areola. Place your thumb around the areola and keep doing it. So, after finishing the deep palpation, please, by the way, in the combined stations, you will not be having time to perform the lymph nodes. Lymph nodes are only for the teaching station. So after finishing the palpation, you can now move to the management. And in the management as well, you can find it is different from one station to another. Why? Because in cyclical mastalgia, you must examine both breasts in everything. Because she told me that I'm only having soreness in my both breast from the history. But in the breast lump, she gave you that she felt a lump in the right breast. So in the other station, you can usually start from the affected side, at least in the palpation. But in cyclical mastalgia, you have to perform both breasts. What you'll find here in this examination, normal. Cyclical mastalgia examination is quite normal. She will give you soreness in both breasts, which increases before the menstrual cycle or at the period time. You will take normal history from her and exclude cancer and trauma. And you will ask about the smoking as well in the lifestyle and the family history, very important. That's why she's going, by the way. And then ask about the 4Ps. Okay. From my assessment, it seems that you're having a condition we call mammogram. We have a condition we call cyclical mastalgia. What
Dr.
is
Ahmed,
this?
you sound as you sort of turned around from your microphone.
It's far?
Yes.
Okay, so what about now?
Better. Thank you.
No, if it's interrupting, please interrupt me. If it's interrupting, please stop me. Because yesterday I told you that you have to tell me, guys, if the voice is interrupting at any point.
Yes, I
Sometimes,
will.
yeah, sometimes it can be some connection problem, by the way. So, is it clear right now or not? Is it clear?
Yes, much better. When you'll be turning away, I will be telling.
No,
Please turn back.
you mean it was far? It was far, or it was
Yes,
interrupting?
it was like it going like very
Uh,
dim. Like
it was far for like few seconds and then it was fine.
Okay, okay. So, diagnosis here will be cyclic nostalgia. What is this, doctor? It is a condition which is there is pain in the breast, which can be related to the cycle. Nostalgia means pain in the breast, and cyclical means related to the menstrual cycle, and that's why you're having it. Why, doctor? No reason, but most probably it happens in the women who are having sensitive brain tissue to the hormonal changes which occur during cycle. So sensitive to the hormonal changes. What I'm going to do, very simple, keep on the painkillers, and you're going to advise her, for example, to sometimes in the cycle, in the menstrual cycle times, in the middle of the period, you can just tell her that you have to like wear like loose bra, which has fit bra, because this can relieve you or comfort you a little bit, because this pain can annoy you. And you'll advise her sometimes to do some to can apply some local anti-inflammatory in case it helps. She is basically worried about cancer. You reassure her that this is not cancer. You have no symptoms suggestive, and this usually is against cancer. Why? It is pain, and there is no lump. Cancer is painless lump. So cancer is against lump. So she has no lump. So why is cancer? Okay, so you are not going to do anything to me. Actually, here there is no need to do anything. This is a very common condition, and it resolves after the cycle itself. Okay, however, we are going to warn you if you feel any lump in your armpit or any change in your breast, please come back to us. So the warning signs are of the cancer here. Another simple station as well. It's very easy really, to score and very easy to pass, and very cooperative simulator as well. Okay, next station. The whiplash injury. The whiplash injury, I don't know why many people hate it, but simply she's a girl, she had a car accident yesterday, and she had jerky movement in the neck. Most important question to ask her here is that have you noticed any jerky movements in your neck after the accident? Why I'm asking this question? Because actually this question, after an accident, especially, if the car is hit from the back, your neck will experience jerky movement. This jerky movement actually is the cause of the whiplash injury. When someone hits you from the back, your neck will jerk. This is what we call jerky movement, and this is what we need. This is what causes the whiplash injury. This is one question to ask. Number two, you will ask her from the beginning of the station when she tells you about her accident and she has a pain in the neck. Ask her, please steady your head and the neck. Keep your head and neck fixed. But say it in a nice way, guys. I mean, do not, for example, most of the people go and say, please keep your head and neck fixed. No, just, okay, can you help me with keeping your head and neck fixed, please? Can you stay still? Like this. Don't give a command like you are commanding the patient, like giving a real order. It's not a military order. Okay, so now you are going to take the history from here. When did this happen? How did this happen? And these things. What are your differentials here? Nothing. Just you have to exclude any neurological problems in the upper limb. This is a red flag. Okay, you will ask about the job, because in any muscle injury we have to ask about the job for fitness to work and physical activity and these things. In the real exam you're going to command her. You're going to tell her, can you help me with keeping your head and neck fixed? You know why we do this today? We do this because we are not sure yet if she is having any fracture or not. It is the first presentation to her. So we have to make sure that everything is fine. Why nervous? I didn't get your point.
Yeah, the problem that during the exams, because of the quickie of the fast changing from one cubicle to another, you will lose your the way of expressing yourself or manipulating with the patient, Yeah, it happened to me. So it would be mask face. That's one of my mistake actually.
Yeah, no, but actually you can help that. Can you help me with keeping your hand in mixed please? Like this. I mean, yes,
Yeah.
I mean, sometimes you just thank God that you remember the order. Just like this. But no, I need you to always, when you are giving comment to the patient in PLAB 2, you have to make it like, for example, can you help me with that? Can you help me with that? Can you do this for me? Can you do this? Like, it's not like a direct command. Why? Um, Actually, if you see it like maybe in the videos, you'll find that you never give a direct order. Yeah, you lose a cool and you lose your concentration many times. I mean, many people, by the way, forget to tell the patient in the beginning that they should fix their head and neck. Many people tell that. But the thing is that if actually you are suspecting any fracture, I mean, if someone is coming with a bad neck pain, definitely ask them not to move their head and neck in the beginning before proceeding and doing anything. Okay, so what's next? Here in this case, simply, you are going to perform the examination. Which examination here? It is the brachial plexus, similar to the brachial plexus examination. Very similar to it. But there is one point I need you to know. You're going to expose the patient as well, again, the neck and the arms. And you're going to do inspection from front, and then spinal and paraspinal palpation from the back. Okay? You will find paraspinal tenderness. Usually the patient will not let you proceed further than this. Now you find paraspinal tenderness. You need to check on the neurology, the nerves. Why? Because still I'm not sure that there's fracture or not. So the red flag is the neurological signs. So you have to confirm them by doing examination right now. You will do sensation and motor very quickly and you'll find that everything is fine. For the sensation, you pick up only the fine and pain sensation, fine touch and pain sensation, very enough. And for the motor, you can choose one or two of the motor. For me, usually I went to the tone and the power. Tone is very easy, and the reflex as well are easier, but they can be challenging for some people. I mean, if you do them in a faulty technique, this can cost you some mark. So what I do, I usually stick to the power and the tone. And for the power, you simply ask the patient to push against your hand. I mean, he will fold both because there is no video for it. Okay? So simply in this case, you'll ask the patient to push against your hands for all the power ranges. Push against your hands. This is what you can do. Can you please push against my hands? Push against my hands like this. One important thing as well to know that you have only to do two motors, not all the motors. Because if you do all the motors, you will not finish this examination. Just two motor examinations. After the motor, you can proceed to the cervical movements. Red flags here are the neurological signs, Dr. Idira. Neurological signs which are the tingling and the numbness and the movement problems. You have to rule them out after noticing this paraspinal tenderness. Okay. What's next? Now move to the cervical movement. You'll find that there is a restriction or limitation in the cervical movement. Why? Because of the pain. Okay, so I fixed the neck in the beginning, and after confirming that there is no problem there is no fracture, how did I confirm that there is no fracture? By doing the neurological signs. Neurological signs are normal. Now I can ask the patient to move his neck. Do cervical movements right now. So the last thing comes in cervical movement after ruling out everything. You can also ask the examiner that I need to see the X-ray of my patient or I need to order X-ray. He will tell you, doctor, no need to do X-ray here. In the management, there's whiplash injury and you will explain and you will treat it. Very simple, like any muscle injury. Have some rest, try to be mobile or try to be active as well. Take some painkillers. Try to not stick to the same position for long. Okay, try to relax, like by taking breaks from sitting in the office. Like very simple, like any muscle injury. And it will resolve on its own within 2 weeks. This is very similar to the brachial plexus, but the brachial plexus station is even easier. Why? Because she is here to see her fitness to go back to work after having or after sustaining brachial plexus injury 1 year ago. So now she is here to see if she's fit to back to work or not. Brachial plexus injury is associated with some motor and some sensory problems. So we are going to ask her about the motor and sensory problems as well. For example, do you have any tingling, any numbness, okay, any pins or needles? How about your movement, the movement of your arms? Actually, it was on one side, on the right side. So you'll ask her, are you able to use it? Are you able to write? Are you able to hold objects? Okay. Do you overuse the other side? And for the movement, we said about it. For the legs, sorry, for the legs, you have also two, because there's sometimes some leg injury. But this resolved at around. What matters here is the brachial plexus examination. Now ask some past medical history, but just ask 2 or 3 questions because this is trauma. It's not important to ask about past medical history. Please take job history. Job is very important. Why? Because you are assessing your fitness to go back to work. So you have to assess the job. Now she is an engineer in the British Navy. So which means that she can lift heavy objects. But she will tell you from the history that she has completed her physiotherapy course. Okay, so I think she is fit enough to go back to work. So we are going to perform the brachial plexus examination, which is very similar to the whiplash, apart from one difference or 2 differences. Number 1, you are not supposed to do the spinal and the paraspinal tenderness here. You're not supposed to do it here. The spinal and paraspinal tenderness. This is number 1. And number 2 as well, you are not supposed to do the cervical movements, the head movements or the neck movements. Why? Because you know very well that this has nothing to do with the movements here, the movements of the neck. One important thing to add, so you deleted 2 things. Number 1, the neck movements, and number 2 as well, you have deleted cervical or the spinal tenderness. But very important to look at the eye. You know why I have to look at the eye and do eye inspection here? For the signs of Horner syndrome. You know, sometimes with brachial plexus injuries, there can be signs of Horner syndrome exactly. So I'm going to look in the eye and I'm going to say that there is no meiosis, no ptosis, no enophthalmos. Meiosis, ptosis, no enophthalmos. Just look at the eye and say these things before doing the brachial plexus. So brachial plexus and brachial plexus here, no need to do cervical movements and no need also to do spinal and paraspinal tenderness. The core here of this examination is the neurological examination of the arms. Okay, what's next? So now we finish these 2 things. Now move to the sensory neural hearing loss or the hearing loss station. She is a 60 years old lady coming from loss of hearing or hearing loss from the left side. First question to ask is that is it complete or partial? Number 2, take history of the hearing loss. Number 3, she is having also vertigo, like dizziness. How to ask about hearing loss, by the way? For the hearing loss, since when it started, how did it start? Has it changed? What about the other ear? And for the vertigo, she will tell you, doctor, and this as well, I feel dizzy. Tell me dizzy. Doctor, I feel that the room is spinning around me. Ask her, since when it started? How did it start? Has it been continuous or comes and goes? Has it changed? Like this, like any other complaint. Okay, so she's having sensory neural hearing loss and vertigo. I know that many people say that it's acoustic neuroma, But you know what I will say in a while. What are your differentials here? You can rule out a Meniere disease, you can rule out any trauma, and you can rule out any infection, especially the otitis media, and any stroke and SOL as well. So rule out SOL and stroke by asking any morning headache, any blurry vision. Then rule out otitis media by asking any fever or flu-like symptoms, so it needs to charge. Number 3, rule out trauma. Have you injured your ear recently? Past medical history is not that significant. Lifestyle, smoking is important. Maybe alcohol as well. Move to the examination. I'm going to examine vitals, general physical, and ear examination. In the ear, I start with the inspection, then the palpation, including what, Dr. Muniba? Palpation including what, Dr. Muniba?
In palpation, we would again start with the auricular, pre-auricular, auricular, and post-auricular.
Yeah, and
Any
what's
tenderness,
important?
temperature change, and then tragus test.
Very good. So do not forget the tragus test, please, in any ear examination. Why? Because I told you in some stations for the ear, they can fail you because of the tragus test.
Yes,
Dr.
I know.
Muniba, after performing the palpation, you will go for the otoscopy, right? When can I go for the otoscopy? I mean, you know what? You can go for the otoscopy if the tragus test is negative. Why? Because the tragus test
That's
usually,
a contraindication.
yes, tragus test positive is a contraindication to the otoscopy. Why? Because if I find tenderness on tragus, and if I find any wax in the ear, I cannot introduce it in the otoscope.
Yes.
Thank you. So now go to the otoscopy. Okay. Usually, maybe they will not let you perform the otoscopy. So what's your next step, Dr. Muniba?
We will do the 8th nerve examination, the Rhinase and Weber's.
How? Rene and Weber. You will start with Rene and Weber, and after that,
Should we do the auditory equity first?
I recommend that.
Okay.
You do the auditory equity first. You just rub your fingers. Rub your fingers or like snap them like this. See?
Right.
But of course, it should be like a little bit quieter. Why quieter? Otherwise, it will be audible by the other ear. Yeah.
Right.
So you should do this like this. I need you to hear. Hear carefully. Mute yourself, Dr. Muniba.
So
See how quiet? This is quiet thing because I need to assess one ear at one time. So this is the auditory acuity, and I will notice that the auditory acuity is limited on the affected side. What after the auditory acuity, Dr. Muniba?
then we'll explain the Rhinase and the tuning fork to the patient.
Yeah.
And then we'll proceed to the examination.
What is a tuning fork?
It's a vibrating instrument,
Okay.
and I'm going to place it in front of your ear first, and then at the back of your ear. And
It's the opposite, Dr. Muniba. It is the opposite.
Yes, obviously, yes. At the back of the ear first, and then in front of the ear. So let me know when you stop hearing the buzzing.
Why do I start with the bone and then I move to the ear?
Because air conduction is better than bone conduction.
Usually, in any cases, normally I always suggest that the air is better than the bone, right? So yes. I usually start with the bone, and I will tell the patient I'm going to place it on the behind your ear. Please, when you stop hearing it, do let me know. So after stopping hearing it on the bone behind the ear, I will place it in front of the ear. If he still hears it in front of the ear, what does this mean?
That air conduction is better than bone conduction.
You know why? The idea here is very simple. That if you place on the bone and it disappears in the bone after a while, but still with this frequency, with this low frequency, it is still audible in the air, this means that definitely it is better in the air conduction rather than the bone conduction. So you know, yes. Because placing the tuning fork over the bone after a while, after vibrating it for a while, the frequency starts dropping. So with the low frequency, he cannot hear it on the bone. But still, with the same low frequency, he can hear it in the air. So this means that the air conduction is much better than the bone conduction. And you repeat
Right.
it on the other ear as well. You will notice that really is reduced in the affected site, right?
Yes.
Then
If
Viver.
conductive loss.
Yes. No, wait. I will diagnose it with Viver.
Okay.
How to do Viver?
Here we'll place the tuning fork on the forehead.
Tuning fork on the forehead. Okay.
I
What
mean
I'm
on
going
the hairline.
what I'm going to tell the patient.
That I'm going to place this instrument on your forehead. Let me know which hair you can from which side you can hear the vibration most.
Yeah. Okay. So tell me where do you hear it better? Right side or left side? So what are you going to do right now? You are going to place it.
Then
You are going to buzz it. You know, guys, to buzz the instrument, you simply touch it to your elbow. Touch it to your elbow, or you can even like rub it. You can rub the tuning fork. But I recommend that, you know, like striking it to your elbow. This will give a vibration. Because me myself, I had sweaty hands. So if I rub the tuning fork, it will not do any buzzing. So I do
right.
recommend that you strike it to your elbow. Any body province in your body, but of course do not strike it to your face. Right, Dr. Maniwa?
Yes.
So what you're going to do next, you now place it on the forehead, and he told you that Weber lateralizes to the right, which means that he can hear it better on the right.
Yes.
He can hear it better on the right, and the air conduction was better than the bone conduction on both sides.
On which side?
On both sides, yeah. So what's your diagnosis?
So the patient would have left-sided hearing loss, sensorineural.
Yes, exactly. If the air conduction is better than bone conduction, this means that it is either normal ear or sensorineural hearing loss. How to
Yes.
differentiate? If the Weber test, if the Weber is normal in both ears, which means that the Weber does not lateralize to any side, this means that it is normal ear. But if the Weber lateralizes to one side, this means sensorineural hearing loss on the opposite side.
Yes.
Did you get it?
Yes. Yes.
Okay.
But Dr. Ahmed, in this sensorineural hearing loss station, they also have otoscope there.
You mean you will
So are we
perform otoscope?
Sorry?
You will perform otoscope?
Okay, so we will perform all the steps like inspection, palpation, Raynaud's, Weber's, Traeger's, otoscopy, everything.
You will perform everything. Okay, no problem.
Okay.
I mean, you say that they will let you do it. They will let you do the otoscope.
Okay.
So
thank you.
yeah. I mean you mean so. So if they let you do, you just do it on the affected ear. Don't do otoscopy on both sides because this will be a big waste of time.
Right. Okay.
Okay. So after that, Dr. Muniba, you are going to tell the patient you're having a condition we call.
That's sensorineural hearing loss.
Why don't you say acoustic neuroma here, Dr. Muniba?
Because I haven't confirmed it with any scan.
Yes.
I can't say it for sure.
The word OMA definitely is any OMA in the body. It's just through scan, through test, through further test. How come you FY2? Dr. Muniba, tell me, you finished the medicine school and in the second day you were able to diagnose neuromas and melanomas and testing?
No, I couldn't diagnose. I can't even
I think
diagnose
even
now.
till now. Yes, right?
Sorry?
I mean, I think even you can't do that up till now.
Yes, I can't say to anyone that you have acoustic neuromas, you have hepatoma, plaques,
Yes,
etc.
exactly. And they don't have even like any facial weakness or any problem with the speech. So how come can I say this? This is number one. Number two, Dr. Muniba, actually, here it could be having many reasons, right? So what I'm going to tell the patient, what is sensorineural hearing loss?
Sorry, say it again. Your voice is.
What is sensory neural hearing loss?
It's a type in this hearing loss, the nerve that sends signals to the brain from the ear, it is damaged, or it's not sending the signals properly.
Okay, very good. So simply sensory neurons, which means that either problem in the neurons or the nerves supplying impulse to the ear, or transmitting impulses from the ear, or sensory, which means that problem in the hair cells, the sensitive hair cells in the ear.
Yes, but we can't tell the patient's hair cells.
Yes,
We
yes.
won't know.
Oh, excuse me?
I said the patient will not know what is hair cells in the inner ear. We can simply say it's problem in the
sensitive hair cells which are responsible for receiving the sound. Very simple, or interpreting the sound. This is, or simply you can say that there's a problem in the nerves transmitting the signals from the ear to the brain.
Right.
So, doctor, why did I have it?
Well, it could be because of many reasons. Sometimes the cause is unknown. Well, it depends on the history the patient has given. It could be because of any fall, any prolonged infection.
Okay. So we need to do further investigations like blood tests and kidney function tests, all the tests, including maybe
Audiometry.
Yes, audiometry. So we are going to refer you to two specialists. Why specialists, doctor? They are going to perform scans, CT scan or MRI, and pure tone audiometry, which is a special hearing test. Doctor, is it cancer? Is it cancer, doctor?
Ulas, why do you think so?
Doctor, because I'm really worried, doctor, about cancer. Just tell me, please, doctor.
At this point, we can't be sure. It could be a possibility, but before we need to confirm it through further test, and the specialist would do the complete assessment for them.
Okay, thank you, doctor. Doctor, by the way, will I go deaf?
Hello?
Will I go deaf?
Well, I think at this stage, we can't really say that, yes, you will go deaf or you won't. Because the damage that has already been made can't be reversed, but we can stop the progression.
Okay, we agree.
Or slow down the progression.
Yes, Dr. Muniba, we agreed before many times that I'm not going to tell the patient, yes, you're going to be deaf, right? What I'm going to say, well, actually, the sensory neural hearing loss, once established, it's difficult to reverse it again. But what we can do is to stop the progression. So, doctor, what we can do for my loss of hearing? We can
provide you hearing aids.
Yes, hearing aids are the only solution. Okay.
Right.
Okay.
Okay.
This is regarding the hearing station or the hearing loss. Let's move to another station, which is the testicular examination. I got it by the way, and it's very easy one. Because you know my first day was full of examinations. All the examinations that you can expect, it came to my first day. Okay, in the testicular examination, there are two scenarios: either normal testis or hydrocele. In the normal testis, he is a boy who came after a conference yesterday. He just noticed yesterday that he has a problem with his testis after a conference. So definitely, he is worried. He just panicked after a conference. So it came yesterday. I should not ask him about, or I should not ask him about, have you noticed any change? How has it affected your life? Don't say it just came yesterday. And after a conference, just elaborate the lump and rule out cancer and UTI, or cancer and STI. The differentials in a testicular lump are cancers and STI. Okay, and maybe hernia as well. You'll ask him about, have you had any constipation or any cough recently? Okay, do the examinations. How to do the examinations with the testicular? I need you to be exposed from below your tummy or from your waist till below. I ensure privacy will be having shuffle. The same scheme or the same entry. But very importantly, please, very importantly, when you start the examination, you will find the mannequin. You will do it on the mannequin and you will start your examination with the inspection. Please do not overlook the inspection here. And the same inspection. I cannot see any mass, no swelling, no dilated veins, no scar, no pigmentation. Okay, and then move to the palpation. Do superficial palpation in both cases very quickly. How to palpate the test? We are supporting with one hand and feeling with the other hand. And the same to the opposite side. I mean, in each test we do this. Support with one hand and feel with the other hand. Okay, you will find nothing on superficial palpation. On deep palpation, you will find nothing as well. So this is normal test. You will tell him that probably it is normal test, but we need to do further investigation. Which investigations do you think? In a testicular lump, we need to do routine blood and ultrasound. If there is a mass in the ultrasound, if it's ever, which is highly unlikely in your case, we can refer you to specialist. Again, like the breast, exactly. We can refer to specialist here, but here the problem is that we refer only after performing ultrasound. Why? Because you can perform ultrasound to any patient, testicular ultrasound here, but in the breast ultrasound, it is a specialized procedure. So you need to send to specialist before it. Okay, if there is a mass, we can send you to specialists, they will take a sample from it. But what is this mass, doctor, that I filled? Simply, you will tell him that this mass is the epidemiologist. Okay, and it's very important to know how the tests feel like, so that you will not be worried anymore. In the Hydrochem Station, very similar station, but the only problem is that he noticed the mass 2 months ago, and it's getting bigger in size. These here are maybe family history. Yes?
Dr. Ahmed, in all these stations, we are going to check the lymph nodes, right?
In the testicular
In all the
examination.
testicular examination. Yeah.
In the testicular examination, if you, and what?
In this testicular lump station, we will mention the lymph nodes, right?
You will not have time. You can try it, but you will not have time as well. But you can try it. Or you can simply, if you're not having time, you can say, ideally, I will check the lymph nodes. Or ideally, I would complete my examination by checking the lymph nodes. The inguinal lymph nodes, like the horizontal and vertical group of lymph nodes.
Right.
And for this, we will know the horizontal is just below the inguinal ligament, parallel below the inguinal ligament, and the vertical is in the mid-thigh. Vertical group.
Okay. Thank you.
Okay. One important thing here is that you will find, I told you the hydrocele is having this mass since 2 months or 3 months, and it's getting bigger in size. Okay. Rule out cancer, rule out infection as well, and trauma. You can rule out hernia as the previous session. How to rule out hernia? Any prolonged cough or constipation. Have you noticed that this mass like maybe comes out on coughing? Okay. The very one important thing is that in the examination, I got it. I told you I got it in my exam. So in that examination, you will find the examinations are normal, but only on the Trans-Elimination Test. You know the Trans-Elimination, you do the superficial palpation.
Dr. Ahmed, I don't hear you.
Can't you hear me? Okay, what about now? Hello?
Yes.
Can't you hear me?
Now I heard you, but before no.
Okay, I'm sorry. So here simply superficial palpation and then deep palpation. For the deep palpation, superficial palpation is very similar to deep palpation as this, but you just have to roll deeper or roll heavier. The thing is that after deep palpation, what you are going to do, after the deep palpation, you are going to do the Trans-Elimination Test. From the medical school, you remember that the Trans-Elimination is that you have to dim the light. We put a torch behind the scrotum and or behind the testis, and then you dim the light. So if you dim the light and you see that the light is coming through this mass, this means that this mass is fluid. So if you see this light is coming through this mass, this means that this mass is fluid, most probably hydrocele.
Dr. Ahmed, on
Yeah?
your exam, was it actually on a mannequin?
Yeah,
Did you
definitely.
see? It was then.
Yeah.
Because the mannequin, I'm sorry.
No, it's fine.
I had this breast examination station, and the mannequin at my academy was totally different. They were huge lumps, and but on the actual exam, the actual mannequin was so soft. I got lost. I couldn't find anything.
No,
So
actually,
that's why I'm wondering.
the academy mannequins are overused by the candidates. That's why I messed up. But in this mannequin, like, can you hear me? In
Yes,
this
sort
mannequin,
of. I can hear.
in this mannequin, like the GMC mannequin, especially the Hydrochem, what I found is that the scrotum was bigger in size. It was obviously bigger in size, and you can also see Trans-Elimination. But the problem is that you have to dim the light, really. Otherwise, because one mistake I made is that I went to the paper to do the Trans-Elimination Test, but I forgot to dim the light itself. You know, if you dim the light, it's much better than going for a paper, because the examiner has bigger paper. So dim the light, you will see really a fluid coming, or you see a light coming out of the scrotum or the test. Okay, and guess what? Sometimes it can come as negative Trans-Elimination. So what if they bring to you, Dr. Elvira, what if all the examinations are normal? What you will say is the diagnosis?
The hydrocele, all the
Exactly.
examinations.
Yeah, you will say, listen, you will say still, if the examinations are normal, you will still say hydrocele. You know why? Because this is the only mass which grows in size without causing any problem, and it is soft and consistent. You didn't find any lump on the examination. I mean, you examined and you find nothing, which means that it's probably not tumor and no lump. But you know from the history that there is increase in the size. So the only thing which increases in size over this short period and doesn't cause any symptoms, it is hydrocele, and your uniform increase.
So that would be a sort of diagnosis of exclusion, like IBS, yeah?
Yeah, I mean, if the examinations are normal.
If nothing,
still,
yeah, I can find it, that means that it's just hydrocele.
Yeah, just say that I'm suspecting condition we call hydrocele. Okay,
thank you.
So, what is the management of the hydrocele? You refer him to specialist. He will discuss the treatment options with them. Most probably it will be evacuated. Doctor, is it cancer? No, I think so. It's not cancer. However, we'll perform the further investigations also to confirm. Give me 1 minute, guys. Sorry.
I don't know, something wrong with my ears. I'm really struggling to hear something today properly, sort of. Zaid, please tell me that my ears are fine.
Hello.
Yes, is my ears, is something wrong with my ears? I don't hear him properly today.
Are you all right?
No, I don't hear
I'm
properly
sorry.
today.
Yeah, I'm here for helping. Can you tell me more, please?
Yeah, today when I said,
Hello, guys. What's wrong with you there?
I said that I was just checking with Zaid, maybe something wrong with my ears.
No, nothing wrong with your ear. I will tell you what happens. When the mic goes further from my speech, actually sometimes this can happen. That's why I'm telling you that whenever it happens, just let me know, because I'm wearing the headset, and sometimes it goes further from my mouth, so I have to keep it closer to me. Otherwise, the voice may interrupt, as you say. Thank you for these notes. Doctor, is it cancer? May I know why you think so? No, actually, he doesn't have any symptoms suggestive of cancer, and it is not cancer. It is a benign or it's a very common condition. However, to perform that or to confirm that, we need to perform the further investigations. Okay, let's move to one other station, which is the alcoholic liver disease. In the alcoholic liver disease station, actually, you will find that the patient is having abdominal distension, and some tummy discomfort from time to time. And he doesn't have any other symptom. But you will find only in the lifestyle. What are your differentials here, by the way? You will ask about any diarrhea or constipation. You will ask about any weight loss. So IBD could be cancer, could be liver problem. How to ask for liver problem? Any Jones, like any urine discoloration. How to ask about cancer, any weight loss. How to ask about IBD, any change in your bowel habits. Move to the examination. Very important, the examination here is that you do the full abdominal examination, the inspection, superficial palpation, deep palpation, and then liver palpation. For the liver palpation, you are doing the palpation for the liver like that. It starts from the right iliac fossa, move in a wavy pattern. Wavy, which means that the tip or the radial border or the lateral border of your hand is hitting the tummy. Very important. So the tip of your finger is hitting the tummy in the wavy pattern. I ask the patient to take deep breath in and out while you are proceeding. You will feel the lower border of the liver enlarged. How to confirm liver enlargement? By doing percussion. So do percussion from above and percussion from below and measure the span. For example, you find that the liver is palpated 3 centimeters below the costal margin, and you find that the lower border is palpated just 2 centimeters above the right iliac fossa. Just try to measure the span by your eyes or if there is a meter. You will say that the liver is enlarged here. Now do the shifting dullness. For the shifting dullness, you start from the mid tummy, or you can start from the umbilicus and then move laterally. To which side? Move to the left side of the patient. So you start from the umbilicus and you move to the left side of the patient. Move till you find that there is resonance. Sorry, till you find dullness. When you find dullness, please ask the patient to turn on his right side. Why I turn to the right side? Because I need the fluid that I felt. I mean, dullness means fluid. When I shift him to the right side, this means that the fluid will be displaced. So if it turns into resonance, this means that this is a fluid, or this is a movable fluid. So again, I find dullness. I will ask the patient to turn to the right, and then I percuss again after turning the patient. If I find resonance here, this means that this is fluid. So I'm going to percuss back again to the dullness point, and this is a confirm. This is shifting dullness. Shifting means that the dullness has shifted from one place to another when I move the position of the patient, when I change the position. And why that? Because the dullness is because of fluid which is movable freely inside the peritoneum, which is the ascites. If you have time, you can do the fluid thrill. You'll ask the patient to place his hand over his umbilicus as well, like in a bridge, and you will like snap one side and feel with the other side from the medical school. And for that, you can watch the video for the abdominal examination on YouTube. It's very easy. Now we will tell the patient that you're having a condition we call alcohol-related liver disease. Why? Because you have been consuming alcohol heavily. From the history, I could find the examiner asked you, doctor, why do you think so? Because from the history, bloating, and from the examination, enlarged liver. What's your next step, doctor? I'm going to do further steps, further scan, or further investigation like blood and urine and liver function test and CT scan. Okay, we will also consider referring him to specialists to maybe do endoscopy or sometimes take sample from the liver. Okay, guys, I will have to go right now. Okay, we will take a 1 hour break. We are left with 10 stations for the examination. We will finish them after the break. Okay, we will finish them quickly. It will be quicker than now. We are left with.
I have one question, Dr. Ahmed. Is this station is on mannequin or on the patient?
It is on the mannequin. You will find the mannequin. Because yes, for the mannequin actually you have to. No, wait. He is a patient wearing a mannequin.
Okay, all right.
Like the breast. The breast is the patient wearing a mannequin. So here he is a patient wearing a mannequin for the enlarged, and they can put enlarged liver on the mannequin actually.
Okay, thank you.
Okay, so we will resume the next. Not there. What you mean by not there?
I mean, how many examination stations out there?
Out there.
Altogether?
Well, I think there are so far like maybe 30.
Back.
Yeah.
Okay.
30, I think. Okay, I will discuss all of them today. No problem.
Okay. Yeah. Okay.
You just follow. Okay. So see you guys in a while after 1 hour. Okay.